Okay, welcome again to the development of the cardiovascular system, which we divided into 3 sessions to make it easier to follow. In this second session, we will try to explain the fate of the sinus venosus and the development of the adult atria. We have separated two atria, but they are still primitive, so they have more development with sinus venosus. We will describe the development of the ventricles, and we will discuss related congenital heart defects related to the development of the atria and the ventricle. Okay, let us start with sinus venosus. Sinus venosus, as it is the venous part, it is related to development of big veins. Okay, so remember, with development of the sinus venosus, we will describe also development of the vascular system, which is the venous system. Okay, so this is very important. This is the venous end of the heart. It has a body and two horns. It has a body. Let us make it easier. And from this body we have two horns, left and right. So this is B for body, and this is the right horn, and this is the left horn. Okay, the embryo, it has three major veins, and this venous blood will go to the sinus venosus so as to go to the atria, then to the ventricle, as we have mentioned in the primitive heart tube. So each horn will receive three veins. The first vein to mention is the blood coming from the placenta, and this is through the umbilical vein. Okay, so we have umbilical vein. This is the right umbilical vein, and definitely we will have a left umbilical vein here. Then we have blood coming from the body of the embryo, the organs of the embryo, and this is through the cardinal vein. Okay, so we have right and left cardinal vein. The third source of blood is from the yolk sac, and this is vitelline vein. I guess you remember, everything coming from the placenta, yolk sac, is called vitelline. Okay, so we have cardinal, left cardinal, and we have left yolk sac. So this is very important in relation to the sinus venosus. We have a body. This body is formed by blood coming from the right side and the left side. The right side receive three veins. The left side similarly receive three veins. These are from the three sources of blood to the baby: from the placenta, oxygenated blood; from the cardinal veins, this is deoxygenated blood; and from the yolk sac, and this is deoxygenated. Remember that the right umbilical vein disappears very early, and usually it has no adult structures. Okay, so this will disappear early, and you know that the yolk sac also disappears, so its veins, they either disappear or incorporate into other veins, as we will see. Okay, so what happens for the sinus venosus? It has, each horn receives three veins: vitelline vein, umbilical vein, and common cardinal vein. from the body of the embryo, from the placenta, and from the yolk sac. And as we have seen, these plots are from the, we have right and left. You can see this is the body of the sinus venosus. We have right horn, left horn. Each horn is receiving 3 veins, okay, umbilical, vital line, and this common cardinal, because the common cardinal itself is formed of anterior and posterior cardinal veins. Let us start with the left side. Why the left side? If I ask you in the sinus venosus, which side is more important? Your answer will be right side, because in the body, the right side of the veins, the right side of the body is venous. Okay, the side of the heart is venous, the right ventricle and the right atrium. So veins formed from this left side of the sinus venosus, usually they are less important than what we will see in the right side. So the left horn and body of the sinus venosus, they will form the coronary sinus, which is the major venous return from the heart. So they will just be incorporated to get blood from the heart itself. The left common cardinal vein becomes small to form a very small, non-important oblique vein of the left atrium, and the left vital line, the left umbilical veins will be obliterated. The left umbilical vein after birth or with birth of the baby, they will be obliterated. What is more important are changes on the right side, and here the right horn becomes absorbed into the right atrium to form its smooth part, which we sometimes call sinus venereum. Okay, so this is very important. Remember that we had the right atrium like this. I don't know why the color changed into blue. Maybe I have touched that. This is the left, the right horn, and here we have the left horn. We mentioned that this left horn and the body will form the coronary sinus, but here we have the right horn. This part will be incorporated and it will be part of the atrium. Okay, so all this part will be merged with the atrium here. It will become part of the atrium. Okay, this is very important. The right common cardinal vein enlarge and forms the superior vena cava. So this is a very important vein, and it is formed by the right common cardinal vein. The right vital line vein becomes the inferior vena cava, and we mentioned that the right umbilical vein disappears very early. Even in the embryo, there is no right umbilical vein. In the umbilical cord, we have 2 arteries and 1 vein, which is the left. So the right doesn't get. So the changes in the right side, they are more important. Right horn becomes part of the wall. Actually, it makes bigger part of the right atrium. The bigger part of the right atrium is formed by the sinus venosus, and we have the superior vena cava from the right common cardinal and the right vital line vein becoming the inferior vena cava. Okay, so changes on the right side are more important than changes on the left. And here let me remind you of the formed atria. So if you remember, the rough part and the auricle of the right atrium, they form from the right half of the primitive atrium, which we have separated by the septum primum and septum secundum, the part here. And uh, the smooth part of the right atrium from the right horn of the sinus venosus. This is now very clear. So if you examine an adult heart, you will see that it has a smaller rough part and a bigger smooth part. The smooth part is coming from the sinus venosus. While on the left atrium, the rough part and auricle, they are coming from the primitive atrium like the on the right side. But the smooth part, and this is again very important, form from the absorbed part of the pulmonary veins. Okay, is formed from the smooth part or absorbed part of the pulmonary veins. Uh, why absorb pulmonary veins? Uh, if you look at the pulmonary arteries on the right side, we have the right ventricle. It gives us one pulmonary artery which divide into right and left. Okay, and then the left will divide according to the lobes into uh, lobar arteries, on the right into two. And do we have this on the left side? Usually on the left side we have the left atrium. We don't receive one pulmonary vein like this one. We don't have left and right pulmonary arteries, pulmonary veins. What actually we have are four pulmonary veins, two on the right and two on the left. If you are following me, these two pulmonary veins on the left, they should merge together in one pulmonary vein, and these two right pulmonary arteries should merge in one pulmonary vein. But actually, this pulmonary vein is part of the left atrium, and actually they should form one pulmonary vein, and this is also absorbed in the wall of the pulmonary vein. Okay, so if you examine the left atrium, you will find that most of it is smooth, and this is coming from the absorbed pulmonary vein and uh, the trunk and the two pulmonary veins, the left and right. Okay, so they became part of the pulmonary veins. I hope this is clear for you. Okay, this all about the sinus venosus and the atria. Okay, so in the if we just remind you of the we had sinus venosus at this side, we talked about it, and this is sinus venosus, we talked about the atria. Then let us separate this part. This part is the ventricle. The ventricle, if we just recap this is the ventricle. Above here we have the atria. It will be separated by a septum growing from down here, and this septum is thick and muscular septum here, and because it is muscular, we call it the muscular septum. I guess you know why we need a muscular septum to separate the ventricle and a membranous septum to separate the atria. Yes, because of the pressure. The pressure in the left in the ventricles is higher than the pressure on the our in the atria. Okay, so this is the ventricular septum and it grows up. If we complete this is the endocardial cushion, and this septum is growing up. When it reaches this part, this septum will stop here. This septum will stop here, the thick muscular septum. So this part will remain as an opening part, and the blood can go from here to this part. This will have a defect here. This is ventricular defect between these two ventricles, and it will be closed by a membrane going down from the endocardial cushion. Okay, so the ventricular septum, the ventricular development, is formed of two parts. This is thick muscular septum and an upper part here, which is membranes. Okay, this is membranes. I hope this is clear for you. Let us recap it again. The interventricular septum, it has thick muscular part, upper thin membranous part, which close the defect. The muscular septum originates from the floor. It goes up crescent shape, ascend in the direction of the endocardial cushion. It leaves small interventricular foramen above, and this is closed by membranous part from the lower part of the endocardial cushion, which makes the membranous septum. If you feel something strange here, this will be that we have an interventricular foramen above, which is closed. So this can be a site for congenital heart defect. Okay, if you look here, this is the ventricular septum, the muscular part growing up. Here we have the interventricular foramen or ventricular foramen. Here, this is the ventricular septum, and this is the membranous part coming from above. Okay. Something to mention are the congenital anomalies related to the atria. We have atrial septal defect. Any defect in the septum primum or septum secundum can be regarded as atrial septal defect. If the foramen ovale doesn't close, and we see this in a baby after his birth, this is called patent foramen ovale. This is again a common anomaly, patent foramen ovale, and usually in this patent foramen ovale there is failure of closure of the foramen ovale. Remember, this is septum primum, this is septum secundum. Okay, but usually in the baby, if the foramen ovale, the defect is small, the blood will not flow, because we know the pressure in the left is higher, so it will close the septum. Even if it is anatomically open, it will not cause any problem unless the pressure on the left is lower than the pressure on the right, and at this case the baby will be severely ill. So sometimes this patent foramen ovale is discovered in a normal baby. The most common ventricular or heart defect is ventricular septal defect, which is a defect in the muscular and membranous part and their fusion. They do not fuse together, so we have failure of fusion between the muscular and the membranous part. They do not fuse together. Okay, so we have ventricular septal defect or VSD. Okay, we have VSD. This is VSD, ventricular septal defect, and this is failure of fusion between the muscular and the membranous septum here. Okay, they do not fuse, and again the blood will not tend to go. If the blood goes from the left to the right, this will just make a shunt, because we have a blood here which is oxygenated going to blood which is non-oxygenated, and it will go again to the lungs. And okay, so there will be no problem for the baby. The last part which we haven't separated yet is the arterial N, because now we have separated the ventricles, and from this ventricle we have bulbus cordis and truncus arteriosus. These two parts, they will give the outflow of the heart. From the two ventricles after their separation, the blood from the right will go into pulmonary, blood from the left will go into the aorta. So these two parts, they should separate into two big arteries, the aorta and pulmonary trunk. So the hallmark of this separation is that these two structures, they are separated by a septum which is not straight. This septum is not straight, it is a spiral septum. We'll explain how. So the result will be a spiral course of the pulmonary and the aorta. They are not, if I ask you in the cadaver, which is on the right, which is on the left, it will not be easier like this, because they are having a spiral course. Okay, let me erase this, make another drawing here, if it is clear for you to explain this. At first here, the septum, the pulmonary artery will first be anterior, and the aorta, and then to the left side. We are talking about when, if the pulmonary artery is at first anterior, it means that the septum here was coronal. Then the septum will be sagittal, and again here it will be coronal. Okay, if the blood going in the pulmonary will first be anterior, and you cannot see the aorta here because the aorta lies posterior. Why the aorta lies posterior? Because the septum which separated them at this area was anterior, was coronal in position, but then the septum becomes sagittal, and this make the pulmonary on this side and the aorta here, and the septum again rotates and separates them into anterior and posterior, but at this time the aorta is anterior and the pulmonary is posterior. I advise you just to follow the course of one, because if you remember that the pulmonary artery is anterior and then left, then posterior, the aorta is the opposite. Okay, this is the septum, spiral septum, just to explain what I have mentioned. And the arrow, the blue arrow is the blood in the pulmonary, and the red arrow is the blood in the aorta. At first, look at the septum. The septum was coronal, and you can see just anterior to you the blood in the pulmonary artery, which then flows to the left because the septum separated it like this. It became a spiral here, and the septum here is sagittal, so the aorta to the right, the pulmonary to the left, and again the septum becomes coronal. At this side, if you look at the blue arrow, it is behind, and it is clear to see the aorta. Okay, so this is the this is very important. It can explain to you what I have mentioned, which is anterior, which is posterior. I don't want you to just this separation of the aorta and pulmonary trunk, it has a clinical implication, which is transposition of the great vessels. The aorta will be on the right, and we have a clinical condition which is called transposition of the great vessels, and this originates from the septum being rotating in different positions. Instead of being the pulmonary artery like this, first coronal and then sagittal, it rotates in an opposite position. This opposite position will bring the aorta to take blood from the right side and the pulmonary trunk to take blood from the left side because the septum rotated in opposite position. This is called transposition of the great arteries, TGA, and this, as a result, the aorta will take from the right ventricle and the pulmonary from the left ventricle. This is a cyanotic heart defect, and this will be very clear in the uh, fetal circulation. Look here, this is the aorta with its three branches here from the arch of the aorta. Due to this TGA transposition, the aorta is taking blood from the right ventricle. It takes this blood and it distributes this blood, and as it is taking the blood from the right ventricle, this blood is deoxygenated and it is giving this blood to the tissues of the baby. So the tissues of the baby, they are cyanotic, they are not taking oxygen, they are lacking oxygen, and the pulmonary artery is taking blood from the right ventricle and it goes to the lungs, to the pulmonary circulation. Okay, because the pulmonary artery taking blood from the left ventricle and distributing it to the lungs, and from the lungs they will come back to the left atrium, and from the left atrium to the left ventricle, and again. So sometimes this clinical condition is called closed circulation. The pulmonary circulation is closed and the systemic circulation is closed. The body is taking deoxygenated blood and giving deoxygenated blood to the heart giving the tissues deoxygen. So usually this baby will survive during embryonic period and early fetal period just because we have a defects here. There will be ventricular septal defect or patent foramen ovale or septal defect, which will allow mixing of the two circulations. If this is not there, the baby will die. And this will explain to you why we have cyanosis. Cyanosis, as you know, is defined as blue or blue discoloration of the baby due to lack of oxygen. Lack of oxygen because of this closed circulation. Okay, so this is transposition of the great vessels. This is the aorta, it is anterior. If you follow it, it is coming from the right ventricle. This is the pulmonary. If you follow it, you will see that it is coming from the pulmonary artery coming from the left ventricle. So in this second part, we talked about the sinus venosus. It is very important in formation of the superior vena cava, inferior vena cava, the smooth part of the right atrium. We talked about the ventricular septum. We have two septa, muscular and one membranous, and we can get ventricular septal defect if we have problems in this septum. We talked about the separation of the aorta and the pulmonary, and they are separated by spiral septum, and we have the spiral course, and we can get congenital anomaly of transposition of the great vessels if this septum is reversed. Instead of its normal position, it is in a reversed position. Thank you very much. I hope you get the points from this second part. Welcome back to the development of the cardiovascular system. We are